So let's talk about the lower eyelids. Effectively, I'm going to talk pretty much about what most people will call tear trough filler. And to do tear trough filler, we have to know about lower eyelid anatomy first. I think you're getting the point as the flavor of these talks comes on, that anatomy is a very useful thing when thinking about fillers, which is a good thing to take home from this. I'm having difficulties with my clicky thing, so I'll just go back here. So very importantly, let's think about the gateway into the eye. So the orbital retaining ligament is the gateway into the orbital space. Effectively, it's an extension of the suborbicularis oculi fascia, and it basically attaches in a circular rim all the way around the orbit of the eye, probably between 1 and 2 millimeters from the orbital rim. That is the gateway of being outside the orbit, and if you traverse it with a needle or a fine cannula, you will now be injecting intraorbitally. And if you're injecting intraorbitally, if you're trying to help someone with their enophthalmos, that might be useful, but most of the cases you're not, and you don't know that that's a good thing to do. So don't inject intraorbitally. Effectively, the boundary between the intraorbital fat and the extraorbital fat is that orbital retaining ligament, and the fat below the orbital retaining ligament is called the suborbicularis oculi fat, and I'll show you that in a second. As we go from side to side with the orbital retaining ligament as well, it gets longer perpendicularly, and that means that that space increases as you get to the mid-pupillary line. So it's a little bit difficult to see just by writing about it. So let's have a look at a side view. So effectively, this is the globe. Around the globe, we have the intraorbital fat. And here, you'll be able to see is this little white ligament here separates, is effectively, here is where we get the connection between the orbicularis oculi and the bone, the orbital retaining ligament. Everything here is intraorbital fat, and then everything below it is suborbicularis oculi fat pad, and then the deep medial cheek fat pad and the buccal fat pad. So when we inject the tear trough, we stay in the SOOF and we stay in the deep medial and the buccal fat pad. So let's have a look at this patient. Here's a patient of mine that I thought showed some good changes that we would want to correct. Here, this is what people recognize normally as a lid cheek junction, because that's where the orbital retaining ligament runs. This is where the infraorbital malar mound, which is the fat above the orbicularis oculi, runs, and this is what we're aiming to fill. The true, I call it sort of a true lid cheek crease. Plastic surgeons, please correct me, but this is the tarsus, basically. And below the tarsus, there's a change in the texture of the tissue that leads to a line just below the tarsus that is the line we aim to be seeing aesthetically when we're looking at the eye. If we're seeing this sort of additional line here, we're seeing an artificial extension of the lower eyelid that is not aesthetically pleasing. So what we want to do is we want to shorten that frame, as Ali described in the frame concept earlier on. So literally, what we need to do with our anatomical position, like I said, was to go inferior to the ORL, deep to the orbicularis oculi, so we're suborbicularis oculi, in the suborbicularis oculi fat pad, and injection above the ORL will result in poor product placement. Now, this is a mistake injection that was sent to me, and literally she came in, she was very upset that this had happened when she'd had a tear trough injection. So what has happened here based on what I've said? Is this injection too superficial, or is it? So effectively what's happened here is they've injected above the orbicularis oculi. The filler has gone above the orbicularis oculi, and it's visible, and it's not retained by the sling of the orbicularis oculi. So it looks like it's enhanced the defect rather than correct the defect. It's too high up as well. It's not been placed in the right area as well. So this is how it looks from the side, and it needed to be high lased in the end, and it needed to be corrected. So be careful with placement. If you're not accurate with your placement, things will go wrong very easily. There isn't a great degree of margin of safety with the lower eyelid. So technique. Patient choice, as Ali said, is very important. Younger patients confers a better result. If you're going to go slightly older, it's better in Fitzpatrick's 4 to 6. And if you're going into patients that are over 50 years of age, this is not really an easy technique to use because they have poor dermal elasticity. The sling of the orbicularis oculi, which is basically acting like a sling to retain those intraorbital contents, is weak. And the fibers of the orbicularis oculi tend to sort of dehiss a little bit and become like an open basket. So anything that you put behind them can easily extrude out. So you're not really going to, into this territory and this territory here, be rewarded with the best results ever. It's a good treatment for the relatively younger patient. So let's have a look at this in practice. If I choose the older range of that patient, well, arguably we've done a little bit better, but it's not by any means a perfect result. But I thought, well, let's give it a try, see what happens, and we got a reasonable improvement, and he was quite happy with that because he wasn't looking for the perfect eye. But it's not, as you can see, there's still sort of hill valley deformities under there, albeit a little bit moderated. A slightly younger lady, Caucasian, better, but not perfect. So, as long as you moderate your expectations and say we're not going to be perfect, that's fine. Fitzpatrick skin type 5, so better dermal elasticity, but still a little bit older. But we're starting to get, a little bit of a better result, even though we're venturing dangerously into older territory. Now, when we get to the younger patients, look at this frame height. And look at this frame height now. And see what I was talking about when we talked about the lid cheek junction and that true lower lid crease. I don't want to see that lid cheek junction anymore. I want to see just the subtarsal crease. So here we've reduced that vertical height. And as you can see, it takes a tired young lady and makes her into a more awake young lady. This is a week later. You can see there's evidence of a small hematoma there that is resolving, but that is a good result because we've used a stronger product, a more high G product, but she also has an intact orbicularis oculi sling that holds that product nicely in place. And that's why we get near perfection with that type of injection. Again, a younger patient, 32-year-old Caucasian lady. Now you can see how problematic this is in younger ladies, and I'll explain to you in a second why. But when we again rely on the fact that she's got good dermal elasticity, a good intact orbicularis oculi sling, good results. So if you're going to stay younger, you'll get better results. The people who are older start to come slowly out of the category of lower eyelid correction. Now, let's look at why that frame increases in size. So this is a paper from Shaw et al. And effectively, he was taking serial scans of patients and looking at bony remodeling over time by measuring sort of height and width vectors of the bony orbit. And he found that with time, this is generally what happens to the orbit. The lateral diameter doesn't change especially, but the oblique diameter from superior medial to inferior lateral here is what elongates with time. And that is why we get that increase of the frame size, as Ali is talking about in his talk just before mine. Now, this actually, he found, had a more accelerated progression in young to middle-aged women. So with men, they had a sort of slower, more linear progression. Now, whether this has to do with hormonal relationships and bony absorption, I can't really tell you. I'm not an expert in that. But it seems to happen at a younger age in women, which is why women need earlier correction of the lower eyelid than men. And it's one of those things, you sometimes see a woman with a perfect face, and he said, you know, you look fantastic, but you're just looking that little bit tired. Why? Because they're starting to develop tear trough problems. So it's an annoying imperfection on an otherwise beautiful face, and it's worth paying attention to because it's so commonly overlooked out there, probably because people are fearful of the anatomy of the area, probably because they're not sure what they want to do in that area, or maybe they're not even looking for it. So let's think quickly about product choice. There's not one ideal product, but we also have to think about other factors that affect our product choice. How intact is the orboculi sling? How lax is the skin in that area? And these are all things that help determine that, the age of the patient, the Fitzpatrick skin type of the patient. So the perceived product choice, I call it the perceived product choice, is that the safer perceived product choice is a lower G prime filler. Something that's already fully hydrated, because if you put it in there, you want to know that it's not going to get more water attaching to it from its hydrophilic nature, and the correction changing over the few days that follow the correction. Something with low cohesivity. So these special products that Ali was talking about, Bellateria Balance, Teosil, Redensity, Juvederm, Volbella, everyone sort of talks to you from a company perspective and they say, yeah, these are the ones to go for. Now, maybe in the upper eyelid, but in the lower eyelid, when you do case after case after case after case, you find that that is a myth. If you just put something of a very low G in the lower eyelid, it ain't going to help. It's too soft. It's not going to create the correction you want. The skin tension and the orbicularis oculi sling won't allow the change in the height of the valley. So, use a higher G prime filler. Here's a little video quickly to show why I individually check fillers that are I'm going to use. I like using a needle. For precision purposes, I like using a needle. So, I want to prove that you can aspirate with a needle, because when I get towards the medial canthus with my needle, I get towards the angular artery. Sorry, that's just a random bit of continuation of my video. I know, and I've aspirated several times from the angular artery, and I just move my needle, put a little bit of pressure on the area, and you don't even get a hematoma because it's a 30 gauge needle. So you can aspirate with some products. Check the product you are using. Now, needle, pros, you get precision, speed, and you can aspirate. Bruising is a con. Higher risk of IV embolus because you obviously can put something into vessels, but that only is at the medial canthal side of your injection. Risk of traversing the ORL, that is a possibility because you won't necessarily feel it with a 30 gauge needle. So there are some risks to using a needle, so if you're more experienced in that area and you want to take those risks, that's fine. Some people will use a 25 gauge 50 millimeter cannula. When they use that, they're helping minimize risk of bruising. They're also less likely to traverse the ORL and stay inferior to it. and obviously reduce their vascular occlusion risk. However, as Ali said, getting into vessels here and firing off an embolus isn't a big problem. Technique, I would first of all lift that lid-cheek junction, because just doing the tear trough correction on its own will help, but if you don't close down the size of the frame by elevating it, by increasing the malar fat, you're not going to get anywhere. So I will inject, perhaps with something like a Juvederm Voluma or Volift, the SOOF and, the deep medial cheek fat pad and the buccal fat pad, and lift up that lid cheek junction. And then I will do the superficial volumization of the SOOF in the tear trough. Structures to worry about, well, you can worry about the infraorbital arcade at the end of the day, but you're only going to cause a hematoma, as Ali says. You cause a preseptal hematoma. It won't look great, but it's not the end of the world. I pretty much think there's zero risk of vascular occlusion. So people worry about this area a lot, but there's no worries about it, because you've got small perforating branches from the inferior orbital arcade. They're tiny, tiny. Even if you break them, they'll bruise, but they're not going to have a big bolus of filler easily placed in them. Embolus blindness, like Ali said, this is not a problem in the periocular area. It's more of a problem in the nasolabial line, which is so commonly done, or the lip, than a periorbital area. Minimal risk to drainage apparatus, because they've got a sort of bony septal protection naturally anyway. So I think tear trough treatment on the whole is a very safe treatment. Go ahead and do it.